angina pectoris. So see, as it is mentioned over here, that it is a chest pain or discomfort caused by the reduced blood flow to the heart muscle. So normally the full name is angina pectoris, but we call it as angina, no problem. So why does this pain occur? The pain will occur because of increased demand, okay, increased demand of myocardium for blood. Okay, so blood is going, but maybe the myocardium has got higher demand. Maybe normally you are fine, maybe during exercise you are feeling the pain. Normally you are fine, maybe you are upset, you are sad, and since you are sad, you are having some emotional stress, you might be getting pain. So why is it happening? It is happening because inadequate blood flow is going to the myocardium during increased demand. Okay, when there is no increased demand, maybe it is fine, or maybe it is not fine at that time also, but basically you are not capable of meeting the demand of your muscle, myocardium. So naturally, if you actually have to know about this anginal drug, anti-anginal drug, you first need to know a little bit about what is angina. So first of all, you have to have an idea about something called as the coronary artery disease. So CAD, are you acquainted with the word CAD, coronary arterial disease?
Sir, ওইটাই তো coronary artery যখন narrowed down হয়ে যায়।
আচ্ছা, so what is that thing called as? It is called as atherosclerosis.
হ্যাঁ।
Okay, so that is atherosclerosis. So atherosclerosis, like for rest of the people, atherosclerosis is a complicated process that involves gradual build-up of fatty deposits, and there is a plaque formation within the coronary arteries. So what happens is, in the first case, in atherosclerosis, is that the endothelial lining gets damaged. So do you know the steps of atherosclerosis formation?
না স্যার, ওটা শুধু জানি।
আচ্ছা, okay, so let me open it up for you. Okay, so let's discuss it here only. So suppose this is your endothelium. This is the endothelial lining, and beneath this endothelium, if you remember, there was connective tissue will be present. There will be connective tissue present over here, like this. This is going to be the endothelium. This is entire endothelium. Now there will be, first thing is that your endothelium gets damaged. So if your endothelium gets damaged because of maybe smoking, maybe hypertension, maybe high cholesterol, so endothelial function gets stopped. Maybe maybe fat deposits are present over here. Maybe in this area there is fatty deposit. So when there is fat deposit, so do you think endothelium will remain flattened or endothelium will go elevated like this? What do you think?
So elevated হয়ে যাবে।
Elevated হয়ে যাবে। And of course outside there is going to be the smooth muscles present. You remember blood vessel histology?
Yes, sir.
So these are going to be the thick layer of smooth muscles like this, and then outermost area you will see that there is present the external layer or adventitial layer. So what you will see that the next step will be, there will be plaque formation and there will be inflammation. In response to the endothelial injury, macrophages will come in and they will infiltrate the arterial wall, and they will take up the oxidized LDL cholesterol, and then there will be something called as foam cell formation. I don't know whether you have read all these things in pathology or not, but there will be foam cell formation. Okay, and then there will be plaque formation. Okay, Do you understand this?
Yes, sir.
Yes, sir.
So now next thing, so here if there is this elevated or damaged endothelium, do you realize that the platelets are going to get activated?
হ্যাঁ, platelets activate হচ্ছে।
Correct. So if the platelets are going to get activated, so this platelet
Yeah.
aggregation will take place.
Yes, sir.
Now if the platelet aggregation starts taking place like this, say platelet aggregation is taking place, so don't you think that there will be clot formation on top of it?
Yes, sir.
Huh. So if there is clot formation over here, then can the blood flow properly through this?
No, sir.
No.
Yes, sir.
So this plaque, what is the name of this plaque? This plaque is called as atheroma. Okay, this plaque is called as atheroma. Now problem is that later stages under high extreme pressure, you might see that this plaque ruptures also. When this plaque ruptures, there will be further platelet aggregation, and when there will be further platelet aggregation, then there can be dislodged clot. What is dislodged clot? Dislodged clot is basically thrombus. Okay, thrombus is dislodged clot. Understood or not?
Yes, sir.
Yes, sir.
Okay, so now what will happen if there is more of these things happening? So you see reduced coronary blood flow will take place. Okay, so this is way number 1. Way number 2 is that there can be vasospasm. In some cases coronary artery spasm can occur. Now if spasm occurs, then again blood flow will be restricted. Okay.
Yes, sir.
And another reason that happens is imbalance of oxygen supply and demand. Okay, whatever myocardial oxygen supply is and whatever myocardial oxygen demand is, if they vary, then there can be again angina. So suppose there is increased demand, suppose there is excess physical activity, okay, because exercise or any other form of physical stress can increase myocardial oxygen demand, or like I said, emotional stress can also do it. That can happen. Now if we talk about reduced supply, suppose there is coronary artery narrowing. So if there is atherosclerotic narrowing, so coronary artery's capacity reduces to deliver the oxygen rich blood to myocardium. So in that case also there can be trouble. Vasospasm can occur, take place. Okay, understood? So what will patients come up with? Patients will come up with chest pain. Chest pain is the hallmark of angina pectoris. Normally, where is the pain? As far as the clinical condition is concerned, though we are not discussing medicine here, but I think this will be helpful in your medicine also, that typical angina presents as a substernal chest pain. Okay, and mainly it will radiate to the left arm, it can radiate to the neck, it can radiate to the jaw, it can radiate to the back. Many patients, they complain of headache also. Okay, so dental pain to mental pain, kuch bhi can happen over here. Now normally many patients, when they feel pain, there are two extreme situations that I have seen as a clinician. Number one is patients sometimes panic and think that heart burned, which has nothing to do with actually heart. It's a misnomer. It's pyrosis. Basically it's a gastric trouble, acid eructation, acid reflux. Many patients consider that it is basically like it is not just heart burning, but also maybe angina. When many people don't even know angina, they will directly think of heart attack. This is one extreme. Another extreme that I have seen is that actually the case is a angina, but the patient is thinking that no, this is basically gastric trouble, and they land up with death. They die. They simply die. Okay.
হ্যাঁ স্যার, আমার দাদুর সাথে এরকম হয়েছে।
হ্যাঁ, so see, this is very common. This can happen anytime. Okay, so over here, this is one more thing. So how do we differentiate? How do we understand whether it is a heart pain or not? See, you should not tell it to the patient, but this is for the doctors, because patients are not at all in a good position to analyze themselves. So this is for all the doctors. So ask the patient about the quality of the pain. If the person says that the person is feeling it like somebody is squeezing the chest, if somebody is feeling like some huge pressure has been applied on the chest, like maybe a heavy stone has been kept on the chest, like it's very pressurizing, squeezing on the chest, then that is angina. In angina, biggest thing is that what I have observed is no patient is capable of pinpointing the pain. Like many a times I have like one or two patients who came up and they will say that I am having pain here, exactly. They will pinpoint with a finger. I immediately know that this is not angina. So I ask the history properly. So sometimes I get that it is maybe really a heartburn. Sometimes I see that, like one patient I have, so he is in the middle age, not even at all at a higher middle age, on the lower level of the middle age, and that person does regular exercise. So after thorough history and even ECG also, I found out that this patient is having just some muscular trouble. Muscle is sore because the person does a lot of push-ups and all, so that is the pain. So this is the thing that like normally in case of angina, a person will not be able to pinpoint that here I am having pain. The person will start showing you the entire chest. The person will say that I am having pain over here and all. So you ask the patient that what kind of pain is that? Is it some discomfort kind of thing? Is it some squeezing sensation? Patient says yes. You immediately start treating the patient. So so you can also do a cross verification. Whenever the person is having such kind of condition, you ask the person to take a sublingual nitroglycerin. Okay, there is something called as glycerin trinitrate, trinitroglycerin. Don't give trinitrotoluene, फटके उड़ जाएगा. So ट्राइनाइट्रोटोलुइन जानिस तो TNT दुम कर उड़ जाएगा. तो not trinitrotoluene, it's trinitroglycerin, GTN. So glycerin trinitrate can be used. Okay, and of course the patient will feel relieved. If after giving the drug the patient is really getting relieved, then definitely it is a case of angina. ठीक है ना? Understood? So ECG is the best diagnostic tool that you can do, and even you can do stress test like TMT, treadmill test is there. Okay, then you can go for a coronary angiography, or you can go for a non-invasive imaging techniques like CT. Do you know what is CT? CT, what is the full form of CT?
Computed tomography. CT though, sir.
Okay, anyone knows what is CT?
So CT or CT scanner?
हाँ, CT scanner is CT. What is CT?
It's computed tomography.
हाँ, very good. So it is computed tomography. It is CT or CAT scan, computed axial tomography, or simply the case is computed tomography. So how do we treat it? So that's what we are going to talk about, the medications and all. That is going to be our next discussion. So let's proceed ahead. So you see, this is what I was talking about. Okay, you cannot see it. Oops. Yeah. So can you see the definition? This is a very nice definition. Chest pain or discomfort caused by reduced blood flow to the heart muscle is often a symptom of underlying coronary artery disease. And you can see that there are different types of angina present. So there is a stable angina, which occurs during, like, it's stable condition, but still there is angina. What does it mean? So it occurs with physical exertion or emotional stress, and it is relieved by rest on nitroglycerin. But you have to be very much worried if it is unstable, if the angina is unstable, because unstable means it is a medical emergency. That means here angina occurs at rest as well as at exertion. When you're exerted, then also it is happening. If you're at rest, then also it is happening. That is unstable. Then there is something called as Prince-Mettels angina. Now Prince-Mettels angina specifically occurs due to vasospasm at rest. Okay, primarily at rest. So if you are at rest and always you are getting that anginal pain, so it is a Prince-Mettels angina or variant angina. and again nitroglycerin helps a lot. And you see on the right hand side the diagram is given, and it will help you to understand more easily. Do you understand this or not?
স্যার আরেকবার বলবেন।
Okay, look at stable angina. So stable angina is more like a case where you have angina, but as a patient you are stable. We tell patient party that okay, now the patient is stable. We tell it, no. So that's what I'm saying. So patient is stable. That means angina is occurring when the person is exerting, when the person is having some exertion, when the person is having some stress. During that time the person is having pain, but when the person is resting, at that time there is no pain. Simple. So that is stable. Okay.
ওকে হ্যাঁ বুঝেছি।
But suppose it is unstable, that means as a patient the person is unstable. That means it is a case of medical emergency. That means be it rest or be it exertion, the person is having angina. Okay.
Yes, sir.
Now one thing I discussed in the previous slide in the introduction part, that sometimes vasospasm, there is no atheroma, just vasospasm. Look at the diagram, bottom diagram, no atheroma, but just the vasospasm is occurring. So even at rest also the person is having pain, because there is no question of deposition, it is simply spasmic blood vessel.
বলছিলাম আপনার কথা শুনে আমার এখন ভয় করছে, কারণ আমার মনে হচ্ছে আমার স্টেবল অ্যানজাইনা আছে। কারণ কি আমি যখনই ডান্স করতে যাই বা একটু বেশি ইমোশনালি ওই মানে স্ট্রেসড হয়ে যাই, তখন আমার এরকম খুব মানে ফিলিং হয়, তো ওই আর কি।
Acha, no issue. Get a ECG done, show it to me. Already I am a ECG analyst, so I can actually read the ECG. I'll let you know. And another thing is that next time carry one tablet of glycerin trinitrate. They're very cheap, not at all costly. Just put it beneath your tongue. Okay, keep it sublingually. See while dancing whether you are getting relieved or not. That is also one cross verification. Okay, so check it earlier, and you will face no trouble, no big deal. Okay.
ওকে স্যার।
But diagnosis should be made earlier, so get all the investigations done ASAP. Okay, so how can we treat these conditions? See, these are certain ways by which we can treat this condition. Like, so you see, we can go for some organic nitrates, we can go for beta blocker, we can go for calcium channel blocker, and we can go for sodium channel blocker. So that's what I was showing over here. We can go for calcium channel blockers, we can go for like these nitrodilators. See that nitrodilator is in the left side picture. So nitrodilators, calcium channel blocker is there. Then you see on the right hand side upper diagram that beta 2 receptor is present. What is beta 2 doing? So if I block it, then what will happen? Lower diagram, beta blocking effects. So all these things, and in the lower diagram you see how at different level they are working. So many good effects you will be able to see over there. Understood? So these are certain examples, certain names. Beta blocker, I told you at that time, atenolol, propanolol, acebutolol. Okay, glycerin trinitrate can come up as isosorbide dinitrate, isosorbide mononitrate. Okay, then simply a nitroglycerin. Okay, these are all organic nitrate example. Calcium channel blocker we just discussed in the last discussion in the antihypertensive drug. Amlodipine is there, diltiazem is there, nicardipine, nifedipine, verapamil. Okay, these are some examples of CCBs. Now sodium channel blocker is very latest. Okay, so ranolazine is very latest. Okay, but we will have a little bit of discussion on that. Understood? There is nothing to understand here only. So let's see what happens and where happens and how happens. So look at the left hand side. Let's start from the beginning. So CCB, calcium channel blockers. So calcium channel blockers slows down the SA node, and naturally calcium channel blocker will slow the heart rate, isn't it? So heart rate will decrease, BP will decrease.
হ্যাঁ স্যার
Correct?
Yes, sir.
Now remember, if you talk about the CCBs, even the CCBs are going to dilate the blood vessel. If blood vessels get dilated, then once again BP will fall. Sometimes remember, even statin is another category of drug. What is statin doing? So statin is preventing formation of cholesterol. Okay, but that is not there in your syllabus as far as I understand. So I'm not going into statin discussion right now in cardiovascular drug. Then I was talking about this ranolazine. See, ranolazine wala mechanism is also there on the upper right side, that there is some sodium ion channel, and through that channel sodium is going to enter in. And now what does ranolazine do? Ranolazine is going to increase that level. Okay, so that's how ranolazine works. We'll discuss all these things in a detail. I think we should proceed ahead. Okay, so this is basically what is important for you. So I have given all the points side by side so that you can have a contrasting data, contrasting idea. But let's understand one by one. First we'll start with the nitrates, or let's say nitroglycerin. So what does nitroglycerin will do? Nitroglycerin is going to be releasing nitric oxide. Now those people who attended the previous general pharmacology lecture, do you remember we discussed actually the mechanism of action of nitric oxide? Do you remember or not?
হ্যাঁ ওই তো হ্যাঁ স্যার পড়েছিলেন ওই কি বলে ইরেকশন ইজাকুলেশন ওই সময়
So do you remember that nitric oxide can cause vasodilation? That is how blood was rushing into the penis.
হ্যাঁ স্যার
Yes.
Yes, sir.
So here also same thing. That, and at that time also I think I told you that sildenafil has got a contraindication. So you see same thing here. If there is nitric oxide release, then there will be vasodilation in the coronary artery. That is how nitrates work. So that means, do you have idea about preload and afterload?
হ্যাঁ স্যার প্রিলোড হচ্ছে ওই যে যখন আর্টারি থেকে ব্লাডটা ভেন্ট্রিকেলে আসছে আর সেমিনুলার ভালভস খুলতে গেলে যে লোডটা লাগে সেটা হচ্ছে আফটার লোড
Acha, I think I should explain.
স্যার ওই মানে অনেকবার বলেছি ভুলে যাই হোক
Okay, suppose this is the left atrium, this is the left ventricle, and this is suppose your aorta. So the basic funda is this, that before, like when, let us suppose the situation is this, that suppose semilunar valve is closed and AVV is closed. During this point of time, the heart has got some amount of blood. Let's say around 140 ml of blood is present over here. So this amount of blood is present in the ventricle when? At the end of diastole or at the end of systole? Or end of diastole or end of systole? What do you think?
স্যার ওটা কি রেসিডুয়াল ভলিউমটার কথা বলছেন
Residual volume?
মানে রেসিডুয়াল ব্লাডটা যেটা ভেন্ট্রিকেলে থাকছে আফটার পাম্পিং ওইটা না
Acha, I am asking or you are asking? My question is
স্যার
that
আমি
this.
ঠিক শুনতে পেলাম না ওটাই
Acha, so my question is this, ki this blood which is collected inside the ventricle, which is there in the diagram, the blood is filling up this ventricle. Ventricle is completely loaded. Now my question is very simple. This blood is collected at the end of ventricular systole or at the end of ventricular diastole?
স্যার ভেন্ট্রিকুলার ডায়াস্টোলের এন্ডেই তো কালেক্ট করছে
Correct. So this blood is collected at the end of ventricular diastole. I can call it as the end diastolic volume or preload. So why it is called preload? Because this is the load present in the ventricle before pumping. Before the person is going to pump the blood, this is the load that is present in the heart. Then what is after load?
স্যার পাম্প হয়ে যাওয়ার পর যেটা থাকছে
পাম্প হয়ে যাওয়ার পর কি থাকছে?
মানে সেমিনুলার ভালভস খুলে যখন ব্লাডটা বেরিয়ে গিয়ে সেমিনুলার ভালভস যখন বন্ধ হচ্ছে সেই সময় আফটার লোড।
Aorta is branching into artery, artery is branching into arteriole. Do you realize or not?
হ্যাঁ স্যার।
Okay. So, do you realize one more thing, that arterioles will be lined by smooth muscles?
হ্যাঁ স্যার।
So, it can also happen that these smooth muscles provide resistance. So, depending, so if the resistance is low, pumping should be easier, or if the resistance is high, pumping should be easier.
স্যার লো থাকলে ইজি হচ্ছে।
লো থাকলে ইজি হচ্ছে, এক্স্যাক্টলি। তো দিস ইজ দ্য থিং, দ্যাট ইফ দ্য রেজিস্ট্যান্স ইজ লো, that means the after, that is called as afterload. Afterload means the force against which the heart has to pump, the volume against which the heart has to pump. So if the vessels are dilated, if the resistance is low, that means the volume present in it is very very low. Volume of blood present in the arteriolar tree is very very low. So afterload is very very low. If the resistance is high, then the volume of blood present in the arteriolar system is high. That means the afterload is very very high. Do you understand now what is afterload? It is the
Yes.
load against which the heart has to pump. Clear or not?
হ্যাঁ স্যার বুঝেছি।
Okay.
হ্যাঁ স্যার।
Acha. So we can say that the nitrates, they are reducing the preload, that is ventricular filling, or not? Because they are dilating they are doing vasodilation. So they reduces the preload and the myocardial oxygen demand.
স্যার আফটার লোডও তো রিডিউস করবে রেজিস্ট্যান্স যখন কমছে।
Yeah, definitely. But main thing is ki it is reducing the myocardial oxygen demand. So definitely, that's okay. I'll show this. Acha. So definitely the clinical indications are going to be ki acute relief of the anginal attacks. They can be used sublingual form, or they can be used in the spray form. Then there are some oral, long acting nitrates also present, which are transdermal. Okay, they are used for prophylaxis, for preventive measures, prevention purpose they are used. Okay, and as far as the side effects are concerned, that is why you see whenever when Dr. Devashmita said that maybe she needs that medicine, I said so freely because usually it does not have serious side effects. So simply there will be headache, flushing. One bad thing is that if her BP, blood pressure, is low, then she can immediately fall down. She can have fainting, syncope or syncope. Okay, because there will be chances of hypotension. Hypotension can take place. So that is the story of nitroglycerin. On the other hand, if we talk about beta blocker, I think we have just now discussed a moment back about beta blocker in the antihypertensive drugs, that the mechanism of action is that they will be blocking the beta adrenergic receptors in the heart. They will reduce heart rate, contractility, myocardial oxygen demand. Okay, are you reading? Are you understanding this?
হ্যাঁ স্যার।
Side effects and all. Okay, so I'm
Yes,
not
sir.
going with the beta blocker, directly moving on to the calcium channel blockers. So among the calcium channel blockers, here like you have this amlodipine, nifedipine, all these things. So they come under a category which is called as dihydropyridines or dihydropyridines. Again, they are going to do vasodilation. Now they reduce the afterload. So if somebody asks you who reduces preload, what will you say? It is the nitrates. But if they ask you who reduces primarily afterload, main effect on afterload, then it is going to be the
calcium channel blocker.
not only that, dihydropyridine calcium channel blocker. Because non-dihydropyridine is not only vasodilation, but they will also have negative inotropic effect on heart. Mane, they will have reduced contraction also. So naturally, if we talk about amlodipine, so they can be used for stable angina, chronic stable angina, as well as hypertension. But if we talk about diltiazem, verapamil, non-dihydropyridine, then they can be used not only for the chronic stable angina but also arrhythmia. Okay.
হ্যাঁ স্যার।
Okay, so now comes up ranolazine. Now over here, for ranolazine, you will see that it works by inhibiting the sodium channel in the cardiac cell. So if sodium channel is inhibited, sodium influx will be reduced. Sodium influx reduced means even the intracellular calcium level will also get reduced. So naturally myocardial oxygen demand will get reduced. See, sodium is required, na? Sodium channel should be open and only then there will be muscle contraction. SA node will fire on the basis of which ion? Because of sodium only. Correct, na?
হ্যাঁ স্যার
So you understand that it can be again used in combination with other anti-anginal medications for chronic angina. Statin, I just told you, atorvastatin, simvastatin, they are going to lower the cholesterol level in the blood. Okay, they will reduce the risk of atherosclerosis and thereby improve the blood flow to the heart. So in case you want anybody to have weight control, then you should also go for statins. And ACE inhibitor and ARBs, as you understand that they are helping in reducing hypertension, so naturally they can reduce the demand of the oxygen, so that is also true, but these are not directly acting. So statin and ACE and ARBs are some extra points that I have added over here. Okay, understood now everyone?
Yes,
হ্যাঁ
sir.
স্যার
Okay, that's it. So this is just that thing I have shown over here in a flowchart manner. Okay, nothing very special. You can understand it. I think just see to it. I think you will be able to understand. No?
স্যার এক সেকেন্ড
Okay. 1 second is over.
না স্যার একটু দেখে নিচ্ছি এক
ও।
মিনিটে। স্যার ওটা একটু মানে বিপির কাছাকাছি একদম হয়
Yeah, exactly. These are all related. We have, there is a group of chemicals. You have to just know how to play with it. That's it. Shall I proceed?
হ্যাঁ স্যার
Okay. So you see, this is a simple thing. How do we go for treatment clinically? So either you can go for type of angina and the individual patient factors, or you can use multiple drugs as a combination therapy. Lifestyle modification we have seen in the last antihypertension also, and follow up and monitoring is very much mandatory. This is, I think, very common, isn't it?
Yes, sir.
Okay, so once again, let's do some practice. Name Mrs. Emily Williams, 58, female. Medical history is hypertension, hyperlipidemia, and this time I have put type 2 diabetes mellitus. Patient complains of chest pain and discomfort during physical activity. I have given you a background also over here written like that, so that she presents to her primary care physician's office with a complaint of chest pain and discomfort that occurs during physical activity such as walking up a flight of stairs or briskly walking for more than a block. The pain typically subsides with rest or use of nitroglycerin. Diagnosis is based on her clinical presentation and medical history. Mrs. Williams is diagnosed with chronic stable angina. I am mentioning it here because this is not medicine class. When it will be medicine, I will not even mention this. Okay, chronic stable angina is characterized by predictable chest pain or discomfort triggered by physical exertion or emotional stress and relieved by rest on nitroglycerin. Once again, I have mentioned it here. So, come again. Treatment plan, fatafat.
স্যার একটু চিন্তা করে নিচ্ছি
Okay. Have you thought?
স্যার
হ্যাঁ
যেটা মনে হচ্ছে
হ্যাঁ
ওই যেহেতু এখানে লেখা আছে আপনার ক্রনিক স্টেবল অ্যাঞ্জাইনা
হ্যাঁ
প্লাস এখানে হাইপারটেনশন আছে,
হ্যাঁ।
তো এই দাঁড়ান কি করবেন না ডাইহাইড্রোপাইরিডিন মানে ক্যালসিয়াম চ্যানেল ব্লকারটা মনে হচ্ছে এখানে ইউজ হবে।
ক্যালসিয়াম চ্যানেল ব্লকার, আচ্ছা ওকে
ডাইহাইড্রোপাইরিডিনস
ওকে।
স্যার এখানে ফার্স্ট অফ অল হাইপারলিপিডেমিয়া আর টাইপ ডায়াবেটিস হচ্ছে, সো ওটাকে কন্ট্রোল করার জন্য আমরা সার্টানস দিতে পারি। তো আর মানে পেশেন্টকে আমাদের মানে কি বলবো লাইফস্টাইল চেঞ্জেস কথা বলা হতে পারে।
ভেরি গুড। হ্যাঁ
লাইফস্টাইল চেঞ্জেসের সময় যেহেতু প্রিলোড বেশি রাখতে পারে লাইক এক্সারসাইজেস এন্ড অল, সেই সময় নাইট্রোগ্লিসারিন দিতে পারি।
ওকে, দ্যাটস গুড। এনিথিং এলস?
স্যার ভাবছি এইটুকুই ভেবেছি আর কি।
Okay, good, fair enough. So you see, first thing is of course lifestyle modification. Okay, so that counseling is very much necessary. Again, low sodium, okay, heart healthy diet, regular exercise, smoking cessation, weight management, okay, common thing. Next thing is that you should immediately start, because see, patient, one thing is written, patient already had a medical history of hypertension. So if there is already a history of cardiovascular risk, then you should immediately initiate aspirin therapy. Okay, usually 80 to 160 or 81 to 162 milligrams daily, because you never know when the blood clot will be forming in her coronary arteries, because she had a history. Okay, so you should go for a antiplatelet therapy, and yes, then you should go for anti-anginal medication, like that depends on actual clinical condition and other factors, but short acting nitroglycerin and long acting nitroglycerin are to be used. Short acting bole to sublingual, that I told you na, spray or sublingual tablets. And you should also teach,
সরবিটেটটা কি নাইট্রোগ্লিসারিন?
of course, so you should teach how to use it and everything. And if you talk about isosorbide mononitrate, isosorbide dinitrate, they are long acting. Okay, so that is to be used to reduce the frequency and severity of angina episodes. Okay, so those things should be there. And then like you said,
আমার ফোনের চার্জ শেষ হয়ে গেছিল, ওই জন্য হঠাৎ করে বন্ধ হয়ে গেল।
acha, okay. So then you should go for the beta blockers. Okay, so if angina symptoms are not well controlled with alone nitrates, then you can add the beta blocker, okay, atenolol or metoprolol. Because why? Because beta blocker will reduce the heart rate, na? So if heart rate is reduced, then oxygen demand will be reduced. Understood?
হ্যাঁ স্যার।
And regular like monitoring and follow up though is necessary. Understood? Clear?
হ্যাঁ ওইটাই আমি ভাবিনি, মানে অ্যাসপিরিন থেরাপি বা ওয়ারফারিন
That
থেরাপি।
is must. That is very much required. Okay then. ठीक है ना? Understood everyone? All right.